Thank you. The rationale for watch and wait, it has been known since 1990s that a complete pathologic response in surgical specimen in patients who had neoadjuvant chemoradiations observed in about 10 to 30% of the cases. And as we all know, radical resection is associated with a significant perioperative morbidities, temporary or permanent stoma, and difficult-to-reduce functions such as a lower anterior syndrome. And patients with a pathologic complete response in specimen have a better oncologic outcome. In one pooled analysis recently, the patients who achieved the complete pathologic response in a surgical specimen had a 83% 5-year disease-free survival compared to the partial responder who had about 65% a disease-free survival. So if we have a reliable clinical method to predict a complete pathologic response, these patients can be theoretically spared of morbid surgery and its functional consequences with a good oncologic outcome. That was the rationale. So the very first series appeared in 2002, and also it came from a Brazilian group. In this study, 52 patients with a distal rectal cancer received a standard 5,040 centigrade pelvic radiations and 2 cycles of 5-FU leucovorin. And their complete response was confirmed by proctoscopy and a negative biopsy. And those 10 patients, so among those 52 patients, 10 patients were deemed a complete clinical responders, and they were watched a median follow-up of 30.2 months. And among 10 patients, to our disappointment, 8 patients had a local recurrence within 1 year. So those are the patients. And of note, there are a lot of patients in this series. There are a lot of people with a tethered and nearly circumferential tumors. So the limitation of this study was there was no T or N staging preoperatively, either by MRI, either MRI or endoscopic ultrasound. And also the criteria for clinical complete response was not stringent enough.